Do you think you've mastered neurology? Let's put your knowledge to the test. We'll cover for core topics neuroanatomy, stroke, neurocognitive disorders, and other neurological conditions. Each topic includes 3 questions, 1 easy, 1 medium, and 1 hard, worth 1, 2, or 3 stars. You'll have a moment to think before we reveal the correct answer, along with a brief explanation from Lecturio's expert medical content. Keep score as you go, and find out how strong your neurology knowledge really is. Let's get started.
Let's start with an easy one. First, the following images show the lateral and medial views of the brain with different arterial territories labeled as A, B, and C. Which of the following correctly matches the labeled territories with their supplying arteries?
And here we see on the medial view, in blue again, shaded in blue, the distribution of the anterior cerebral artery. So most of good part of the medial, all the medial side of the frontal lobe, all the medial side of the parietal lobe, essentially, is being supplied here. Now we want to take a look at the middle cerebral artery and the territory that it supplies, and that's the area that's shown in through here. The territory supplied by your middle cerebral will be the lateral frontal, lateral parietal lobes, as well as a portion of the temporal lobes. With respect to the internal capsule, it's going to supply the genu and its posterior limb. And this is the vessel that will give rise to branches that supply most of the structures that belong to the basal ganglia. Posterior cerebral artery is next, and we can see that its distribution on the lateral side is somewhat minimal, more so on the medial side. It will supply the occipital lobe, which we see here. It supplies this portion of the temporal lobe laterally, and it's also responsible for the arterial supply to the midbrain, which would be a structure outside of the cerebrum or the cerebral cortex, obviously. That would be a brainstem structure. Arterial supply of the posterior cerebral artery here in a medial view. We can see it supplying the occipital lobe, and then we see it supplying this area of the temporal lobe.
A 55-year-old man presents with inability to recognize familiar faces, including those of his family. He describes all faces as strangely unfamiliar and cannot even recognize himself in the mirror. Which of the following structures is most likely damaged?
Here we're looking at the occipital temporal medial gyrus. That is shaded here in green. And what you need to remember about this region of the temporal lobe is it's involved in face recognition, and that allows us to identify individuals that we've had contact with. A lesion of this area would result in face blindness, so we'd be unable to recognize the faces of individuals. So they would be like meeting that person for the first time over and over again.
A neurosurgeon is planning to access a vestibular schwannoma at the cerebellopontine angle. She plans to enter through the internal acoustic meatus. Which of the following structures is she most at risk of damaging during the procedure?
The third and final fossa is referred to as your posterior cranial fossa, and the openings of interest in this particular fossa would be first the internal acoustic meatus. See that opening right in through here in the temporal bone. This particular opening is going to transmit cranial nerve number 7, the facial nerve, as well as cranial nerve number 8, the vestibulocochlear nerve.
A 45-year-old man with a history of hypertension, hyperlipidemia, and diabetes mellitus presents for right-sided weakness and speech dysfunction. The patient went to bed last night in normal health. When the patient awoke this a.m., his wife says that he did not have symptoms and was able to speak normally. Around 10:30 a.m., he went to his shed to work in his shop. At around 11:30 a.m., she found him in the shed, on the ground, without the ability to move his right side and mumbling. EMS was called, and he was brought into the emergency department, where he remains weak and mumbling on examination. He has right hemiplegia involving the arm and leg as well as right facial droop. He is unable to speak, mumbles incoherently, and is able to follow a simple command to open and close eyes. What is the next step in management?
Well, EKG is never a bad thing to do, but it's not the next step in management for this patient. Paroxysmal AFib is a potential cause of a large vessel occlusion, and this patient's symptoms, the territory of a brain that's involved, is quite large. He has hemibody symptoms and a dense aphasia, so we're worried about a large vessel stroke. And the etiology may be paroxysmal AFib, but that's not the first thing we'll do for this patient. We could think about aspirin, and aspirin is a good idea for patients who are suffering a cerebrovascular event. But again, it's not the next step or the best next step for managing this patient who presents within a window of time where we can intervene. MRI of the brain will be done for this patient. We want to evaluate whether he's had a stroke and really define the extent of that stroke. But again, this patient has presented within a window of opportunity for an acute intervention, and so MRI of the brain is not needed to diagnose the stroke. Clinically, this patient meets criteria for an ischemic stroke, and so the best intervention and the best next step in management is to evaluate the patient for TPA. The patient presents with a last known normal within 1 hour of symptom onset. His symptoms are consistent with a left MCA syndrome. We need a CT of the head to evaluate for hemorrhagic stroke and rule out a hemorrhagic stroke, and then we would consider and proceed with the intervention with TPA administration. And so here's a table that's an important reference as you're considering some of the major stroke syndromes, their vascular territory, and their presenting signs or symptoms. We see that left MCA strokes have a characteristic presentation, often with aphasia and hemiparesis, and the other findings you see here. In contrast, right MCA strokes don't involve aphasia, but present with similar hemiparesis and hemisensory loss, and neglect and other right-sided brain symptoms. Left PCA strokes frequently present with occipital dysfunction and visual impairment, visual field defects, similar to right PCA strokes, which present very similarly with visual field defects. Vertebral strokes have a distribution that is deep within the brain stem in that medullary region, and so we see the dizziness, vertigo, nausea, quadriparesis that are present in medullary strokes.
A 67-year-old man presents to the emergency department with acute onset left-sided hemiparesis and facial droop that began 90 minutes ago. He is alert and stable. A non-contrast head CT is ordered. Which of the following statements regarding imaging, sensitivity, and findings at this stage is most accurate?
So you want to begin with a CT scan of the head because of its quick access and the ability to exclude hemorrhage. Ischemic strokes, however, may not be visible on CT for several hours. MRI is actually the most sensitive examination for early ischemic stroke, and diffusion-weighted imagers are the ones that are the most useful. They demonstrate changes of an acute stroke within 20 to 30 minutes of onset. However, MRI can be hard to obtain and can be time-consuming. You don't want to waste those precious few minutes looking for an MRI. And this is why stroke imaging is usually held off only for patients looking for secondary signs of stroke.
A 74-year-old presents with cognitive dysfunction, with the patient and family reporting 3 to 5 years of progressive memory loss and executive dysfunction. Symptoms began about 5 years ago with difficulty remembering names, dates, directions, and misplacing items like keys, as well as trouble driving. Over time, the patient became socially withdrawn, stopped managing finances, and required help with cooking and baking over the past year. On exam, the patient is alert, awake, and oriented to location. There is significant memory impairment. 3 out of 3 items recalled immediately, but only 1 after 5 minutes. The patient can name objects, is fluent, and follows commands but shows reduced attention, poor backward-month recall, and a diminished fund of knowledge. No focal deficits are noted. What is the most likely diagnosis?
Well, this is not the typical presentation of frontotemporal dementia. Frontotemporal dementia affects primarily the frontal lobes, the temporal lobes, and behavior function. We see symptoms of speech aphasia, speech dysfunction, semantic dementia, and behavioral changes, which are not prominent in this case. This is not the typical description of Lewy body dementia. Patients with Lewy body dementia present with cognitive dysfunction, often subcortical dysfunction, as well as early Parkinsonism, which we don't have on exam or by report for this patient. This is not mild cognitive impairment. The patient's cognitive dysfunction is significantly affecting their daily function. They have retracted from social activities, are no longer working, and now there's a concern about cooking, baking, and safety in the home. This is a typical presentation of a patient with Alzheimer's disease.
A 68-year-old man presents with visual hallucinations, cognitive impairment, and mild bradykinesia. His family reports that his confusion and hallucinations began around the same time as his Parkinsonian symptoms. He has minimal tremor and reports acting out his dreams at night. Which of the following is the most likely diagnosis?
It's important to evaluate in patients who may be presenting with an alpha-synucleinopathy whether the cause of that is Lewy body dementia or dementia from Parkinson's disease, and the time course of the onset of their cognitive dysfunction and Parkinsonian symptoms is important. In Parkinson's disease, we see early onset of Parkinson's disease, bradykinesia, rigidity, postural instability, and often tremor. And following that over time, years later, the development of mild cognitive impairment, and then Parkinson's disease dementia. So dementia is a late finding in PDD. In contrast, in dementia with Lewy body disease, patients develop early cognitive dysfunction, typically within the first 6 months of the onset of their Parkinsonian symptoms. And this is critical historical information that differentiates.
This image outlines the clinical features of Parkinson plus syndromes labeled by column. Each column corresponds to a different syndrome. Match each number in the image to the correct diagnosis.
And there are a number of things that I want you to remember about these syndromes. Number one, they're all Parkinsonisms. So all 4 of these conditions present with bradykinesia, rigidity, and postural instability. That's really, really important to remember. However, there are also some unique features of each of these conditions that are unique to the condition and help us to establish the diagnosis. With Lewy body dementia, we see early dementia as a prominent feature in those patients. So dementia begins within 1 year of the development of Parkinsonian symptoms. We can also see hallucinations in these patients, and neuroleptic sensitivity is common. We use neuroleptics to manage some of the symptoms we can see when patients are hallucinating or agitated, and these patients will develop severe sensitivity and become agitated and confused and may need hospitalization as a result of initiation of neuroleptics. And those features are supportive of a diagnosis of Lewy body dementia. Next, multiple system atrophy. The key features to this syndrome is early autonomic dysfunction. So we think about orthostasis, erectile dysfunction, and incontinence. And early findings any of those three findings early in the course of the Parkinsonism should prompt the consideration for multiple system atrophy. Next, let's talk about progressive supranuclear palsy. The key things we see there are twofold. One is down gaze impairment. So these patients have early vertical down gaze palsy. They can't look down. As a result, they have frequent falls, and we see falling. In Parkinson's disease, falls are late, and PSP falls are early. This is also an axial, akinetic, rigid Parkinsonism. So patients have difficulty moving, and they are very, very rigid, often in the axial musculature that controls our posture and axial tone. Patients may have other brainstem symptoms, dysphagia or oral dyskinesias, or dysphonia. And then lastly, corticobasal degeneration. This is a really unique and kind of strange, uniquely strange syndrome. Here we see that it's prominently asymmetric. Patients begin with very asymmetric symptoms, and we see a few things: apraxia, alien hand, and cognitive deficits. And this owes to its predilection for the parietal lobes. Apraxia is motor planning. So these patients are able to move, but they just can't form the plan for how to do it and what they need to do. Alien limb is an extreme variant of that, where a patient's limb will be alien to them. It will shave on its own, it will cook on its own, it will write things that the patient doesn't want to write. It literally is alien. It does what it wants to do, and the patient does not appear to be in control. Those findings of early visuospatial dysfunction and early asymmetric apraxia or alien limb should raise suspicion for corticobasal degeneration.
Which of the following is the best justification for delaying lumbar puncture and obtaining neuroimaging first in a patient with suspected meningitis?
Do we need to do imaging before our spinal tap? Well, oftentimes patients get imaging. They come into the emergency department and a CT of the head is done, and we know what that looks like before the spinal tap. But not always. And there are 5 indications for getting imaging: a CT of the head, a computed tomography, a CAT scan of the head, or an MRI prior to lumbar puncture. And these are the 5. If the patient has a focal neurologic deficit, there could be a mass lesion in the brain. That mass could cause a pressure differential, and we wouldn't want to LP that patient without looking at the imaging. If there's a new onset seizure means a mass lesion in the brain until proven otherwise, and if there's a mass lesion in the brain, there could be a pressure differential, and we need imaging before evaluating that patient. Papilledema. Papilledema means increased intracranial pressure until proven otherwise, and that is coming from a mass, again, until we have imaging that says that it's not. If there's a mass lesion, there could be a pressure differential. We wouldn't want to LP that patient unless we have imaging. Abnormal level of consciousness. We can't do a comprehensive exam in many of those patients to look and be convinced that there's not a focal deficit or some type of papilledema. And so again, abnormal level of consciousness impairs our ability to look on exam for a new mass lesion, for a pressure differential, and those patients need imaging. And then the last indication for imaging before LP is an immunocompromised state. Weird things happen, different things happen, and patients don't always present with the typical symptoms. So it's harder for us to trust our history and exam in patients who are immunocompromised, and we need imaging to show that there's not a pressure differential, that there's not a risk of herniation with a spinal tap, and we get imaging before spinal tap in those patients.
A 12-year-old presents for evaluation of multiple complaints. The patient initially began seeing ghosts when falling asleep at night, starting several months ago. Over the past 2 months, her school performance has declined. Her teachers would find her asleep in class. At one time, after the fire alarm went off, the patient collapsed in the middle of the classroom. There were no seizure-like movements, and she awoke in normal health after this event, though she was agitated. The patient's parents initially attributed these symptoms to her poor sleep. This past week, she had an episode in which she woke up but was unable to move for several minutes and had to just lie in her bed. Concerned, her parents have brought her in for evaluation. What's the most likely diagnosis?
Well, Well, this is not consistent with a presentation of schizophrenia. The patient does have hallucinations, but there are other symptoms in this case suggestive of an alternative diagnosis. This is not consistent with a presentation for migraine. Migraine can cause paroxysmal neurologic symptoms, but again, there are other features occurring in this patient, cataplexy, sleep paralysis, that raise strong suspicion for an alternative diagnosis. This is not the presentation of a seizure disorder. The patient had a paroxysmal episode in school, and seizure would be in the differential diagnosis for this patient, but it does not explain the constellation of findings, including cataplexy and sleep paralysis. This patient is presenting with the typical clinical constellation of a diagnosis of narcolepsy. The patient has hypnagogic hallucinations, cataplexy, sleep paralysis, all of which are characteristic of this condition.
A 57-year-old woman has a past medical history of HTN, DM, and a history of mild headaches. Headaches were well controlled until 6 weeks ago. Now, she has developed bifrontal throbbing headaches that are relieved with lying down and worsened with sitting up to the point where she does not want to get up in the morning. No photo or phonophobia, nausea, or vomiting. Initially thought to be sinusitis and treated with antibiotics, but she had no improvement. A brain MRI is obtained. What is the treatment for this headache?
Well, for an ENT, we really don't get a history of trauma or a traumatic CSF leak that would have given rise to leaking of the CSF from the head and neck area. So a referral to ENT is likely to be low yield in this patient, though we're getting close to the potential etiology. Starting acetazolamide won't help. Acetazolamide is a medicine used for high-pressure headaches, and this patient has the description of low-pressure headaches. Acetazolamide will likely worsen this patient's headache syndrome. What about antibiotics? We see smooth dural enhancement. That's a finding we can see in meningitis. Though imaging in meningitis tends to be focal. We don't tend to see this diffuse, smooth pachymeningitis with an infectious process as we do with this low-pressure headache. And so here, this suggests a non-infectious etiology. In addition, the patient is afebrile and not otherwise ill, which would be additional clinical symptoms that would point us in the direction of an infection. And so in this case, we should evaluate for a spinal dural tear. This case indicates a patient who's suffering from a low-pressure headache. The headache is relieved by sitting down and present upon rising up, and we see the typical MRI findings of a low-pressure headache, diffuse dural thickening, and on other sequences, we may see other classic features that point us in this direction. Low-pressure headaches can be caused by reduced CSF production, or a leak, where the spinal fluid is leaking out and there's less spinal fluid in the CSF space, and that contributes to this patient's symptoms. And the best treatment is to block that leak, and patients will have rapid recovery and resolution.
And that's a wrap. How many stars did you earn if you scored 3 to 12 stars? You're a neurology rookie, off to a great start on your learning journey. If you earn between 13 and 25 stars, you're a neurology pro. You've got a solid foundation, and if you scored 26 to 36 stars, congratulations, you're a neurology master no matter your level. Keep building your skills with Lecturio, your all-in-one study companion for success in neurology. Drop your score in the comments and tell us which topic you want to test next.